Good evening, friends. Welcome to 46th episode of 4D, where we do a detailed discussion of Indian diabetics. Today's episode, we have a very interesting guest and we have a very important topic. The topic is how Indian diabetics are different compared to the Western and Caucasian counterpart. We all know that diabetes is prevalent in India. It's almost like a jungle ki aag. The prevalence is very, very high. Why there is so much high prevalence of diabetes, we have discussed many number of times. But after that, another important question that arises is we are more prone to diabetes, but we are more prone to develop complications of diabetes. So how Indian diabetics are different? Do we need some different approach? Do we need something to be done in a more proactive manner and an earlier fashion? Because our diabetes may not be exactly what is written in the Western books, may not be exactly what the Western counterparts see, may not be exactly like the Caucasian counterparts. So, for this detailed discussion, we have a wonderful guest today, Dr. Geeta Lakshmi. She is a renowned endocrinologist based in Chennai. She's trained from the best of medical schools in India. She's done a DM endocrinology from Amrita Institute of Medical Sciences, Kochi, and she's currently a senior consultant endocrinologist at Dr. Kamakshi Memorial Hospital in Chennai. So, welcome, Dr. Geeta Lakshmi, and we'll look forward to having your academic inputs, and we look forward to having your wise experience and learn from them.
So, today's topic would be why Indian diabetics are different. So, as we know that we are becoming the diabetic capital of the world, and we have an alarming increase in prevalence of diabetes. And this prevalence is not only across the urban areas, but there's an alarming increase in rural prevalence of diabetes as well. So, I think now we have to wear a new set of glasses and we have to approach this problem from a new point of view. So we have to look at why this increased prevalence is happening, how Indian diabetics are different, and not only that, how our therapeutic approach can be different so that we'll be able to tackle this alarming problem in a better way in the years to come. So these are the differences in the physiology part between the Indian and the Caucasian population, and this is why we have an increased prevalence of diabetes. We are a very unique phenotype. So, Asian Indians, we have an onset of diabetes at a very early age. Recent days, we are seeing more and more population in their 20s and 25s becoming diabetic, and we have an increased prevalence of abdominal obesity despite a relatively lower body mass index. This is primarily because of increased visceral fat deposition in the Indian population, and not only that, we have an increased level of insulin resistance in our population, and there's an early decline in beta cell function. We Indians are genetically predisposed to a lower beta cell mass and a lower beta cell function at a very, very young age, and that is why we are prone to diabetes at a very young age compared to Westerners. And not only that, there's an increased inflammatory markers in our circulation, such as high sensitive C reactive protein, which is directly proportional to the increased prevalence of coronary artery disease in our population. That's why we develop complications at the earliest, leading on to an increased risk of morbidity and mortality in Indian population. So, because of this increased cardiometabolic risk and increased cardiorenal risk, I think we need a personalized approach which is relevant to the unmet needs. And that's how we should customize and we should make our approaches tailor made for the Indian population so that we address the various metabolic risk factors and the glycemia simultaneously from a very, very early age. So, along with the physiological changes, so we have a lot of differences in the lifestyle as well. And like many cultures across the world, the daily life in India is changing. So, the Western diet is becoming more and more popular, more use of refined carbohydrates, more use of processed foods and trans fats. And as the urbanization of cities continue, more people are leading less active sedentary lives, and after the COVID many people are working from home as well. So there's almost 10 to 13 hours of continuous sitting. So we know sitting is the new smoking, So, sitting has such an increased risk of metabolic problems, so leading on to increased risk of diabetes and increased risk of cardiac conditions as well. And we are leading more and more sedentary lives, primarily due to gadget addictions. Once the people log out of their systems, they want to spend their time with glued on to the television or glued on to the gadgets. So these are the factors which lead on to lack of physical activities, increased visceral obesity, and increased prevalence of obesity as well. And there's an increased ordering of outside foods which contain more and more processed foods, more and more trans fats, and more of sugar based items. And the other factors which leads to increase in prevalence of diabetes is the changes in farming and habitual practices. That is, because of the green revolution, we have more access to rice, especially the white polished rice, and less use of millets, which have an increased dietary fibers, which can actually cut down the risk of hyperglycemia. And there's an increased availability of packed and processed foods, and there's an increased access to sweet cuisines. That is, especially the high fructose corn sugar syrup based drinks what we have, and the bakery based foods sugary items what we have, and the risk of increased social stress and increased work stress our young population is facing. Because of that, they are no longer involved in physical games. It's more of gadget based games, sitting in a single place, and lack of sleep, more of smoking and alcohol. The societal practices are more and more changing. And also, the perception of diabetes is also changing as well. So, these are the challenges posed by type 2 diabetes in India. There's an increased prevalence in both urban and rural areas, alarmingly, and there's an increased prevalence among young people, as I told you earlier, because of the work related practices. More and more work from home, sitting at a single place working, more and more glued to gadgets, and even increased risk of childhood obesity as well, and limited access to healthcare facilities, especially in the rural areas. Though increased access to food, increased access to trans foods are available, but still there is a limited access to healthcare facilities. And there's an increased prevalence of prediabetes. There's an increased prevalence of obesity, polycystic ovarian syndrome in our population, which leads on to increased risk of gestational diabetes, which transforms into postpartum prediabetes and diabetes. So, not only this, when a GDM mother gives birth to a child, there's an increased risk of macrosomia. The fetus and the baby born with a higher cardiometabolic risk right from the start. So this is something called as transgenerational risk of diabetes. So GDM is becoming gestational diabetes mellitus is becoming the mother of all diabetes. So the diabetes starts from the womb. It no longer starts from the adolescent age. It starts from the womb, right from the fetus, where there's a high inflammatory pre-diabetic environment, which transforms into childhood obesity, which in turn transform into diabetes at a very very younger age. And there a delay in diagnosis of diabetes in well, especially in the women population as across the rural areas, because of the decreased access to healthcare, because of the decreased awareness about the need for diabetes screening. And all these leads on to an increased burden on the health economy. There's a high cost of disease management, because diabetes doesn't stop with screening, diagnosis, and management with medications. It also leads to an increased risk of cardiac complications. And when a diabetic patient goes on to have a myocardial infarction, the risk of the rate, the cost of management of these diseases, the cost of doing an angioplasty, the cost of doing a bypass surgery is also going to go up. And there's a rising rate of diabetes complications as well. So, along with the genetic and environmental factors, low disease awareness among the public, and there's a suboptimal diabetes control, which is because of the clinical inertia that happens. More often than not, We start with lifestyle and a single agent to tackle diabetes. So, this leads on to exposure of our patients to hyperglycemia for a strong period of time, which leads on to hyperglycemia related to increased risk of complications as well. So that's why a proactive approach to treating diabetes is recommended. This is what I've been telling about. There frequently there's a delay in advancing from monotherapy to combination therapy. This results in a suboptimal glycemic control that increases the risk of micro and macrovascular complication. And hence, therapy should be individualized. We should consider early combination therapy, and we should reinforce lifestyle modifications. That is why the diabetes reversal programs are gaining such popularity, because they are not focusing on the medications alone, they are focusing on the other factors, like they are focusing on healthy dietary practices, healthy physical fitness practices, and not only that, they also offer counseling with a psychologist so that the patients can de stress and the mental health burden also comes down. So, stress related cortisol levels come down so that they prevent further worsening of hyperglycemia. So, all these approaches combined lead on to the improvement in the glycemic levels. And from a physician's perspective, multiple drugs with various mechanisms of action are required in combination to manage the various pathophysiological abnormalities. And hence, combined therapy with DPP4 inhibitors and SGLT2 inhibitors target several pathophysiological pathways. So that's why we need newer agents which can tackle the multiple physiological aspects of diabetes. So this is the latest combination that's been approved, that is the use of SGLT2 inhibitors and DPP4 inhibitors, fixed dose combination. These two molecules are very pertinent partners to metformin in providing a meaningful glycemic control. It improves the metabolic profile of patients, and it's preferred for patients, especially even though the patients are young, but the patients are obese, hypertensive, and having dyslipidemia. They have a higher predisposition to cardiac events, especially people with family history of cardiac disease and renal disease. So they are also predisposed to cardiac and renal disease. Hence, an initial combination therapy with an SGLT2 inhibitor and GPP4 inhibitors can be considered in patients presenting with high HbA1c levels, especially people who have HbA1c levels 1.5 percentage above individualized target limits. And this is why these drugs are chosen in patients with high cardiovascular risk. It reduces body weight, it takes care of blood pressure, it has a negligible risk of hypoglycemia, there is no risk of UTI, and it's safe and cost effective, and it also improves glycemic control. So that's why this is a suitable option for Indian type 2 diabetics. It's a safer, rapid, and sustained glycemic control is achieved. It improves both the beta cell function and also the insulin resistance, which are the primary pathophysiological mechanisms. And on the other hand, it improves the blood pressure and it causes reduction of body weight. Thus, it offers extra glycemic benefits as well, and it reduces pill burden. And overall, it is a cost effective option.
So, Dr. Geeta Lakshmi, you talked wonderfully about the differences between the Indian diabetics and the Western counterparts, and clearly, the approach also we talked about and how we need to have a more proactive approach given the overall scenario. The first question that comes into my mind is regarding the prevalence of diabetes. So, there is such a high prevalence of undernutrition in our country. So why is diabetes, which is considered a disease of people who are more fat, more obese, especially type 2 diabetes. Why is such a high prevalence of diabetes is there in our country? Is there a relation between the two? And why is India called as a diabetes capital of the world?
Thank you, sir. Thank you very much for this opportunity. Uh, so, so diabetes, it's primarily a lifestyle condition. It has actually alarmingly gone up across all age groups in India, to such an extent that diabetes is called as the India is called as the diabetic capital of the world. It almost accounts for almost 17 to 20%. India accounts for 17 to 20% of total number of diabetic patients in the world. And according to 2019-2020 data, there were almost only 80 million people with diabetes in India, and they were expecting this number to go up to almost 135 million to by 2045. But the recent data, which was even more alarming, the recent ICMR study that had gone up, we have already crossed this landmark and we are almost up to 136 million diabetics in India. So it's a very very alarming figure, and it creates a lot of burden across the health economy in especially in a developing country like India. Though we call it diabetes a primary lifestyle disease, we were expecting this disease to go up only in the primarily in the urban population. We are wrong. So the diabetes is increasing rapidly at both rural and urban populations in an equally alarming manner. Recently, a study showed that there are not much difference across the states and across the regions. If you split it into rural and urban differentiations, it's almost the same. See, in around 1960s to 1970s, the prevalence was around 2% in the rural areas and around 3.5 to 4% in the urban areas. Now it's almost 17% in the rural areas and 20% in the urban areas. So no more there is a difference. This is primarily, I think, it's an effect of westernization in our country, the adoption of multiple Western practices in our country, and right from starting from childhood, the increase in childhood obesity, and then going on to lifestyle changes in the adult population, like complete lack of physical activity and the change in dietary practices. I think this has contributed to such an increasing prevalence of diabetes across our population. I think that's the reason why we are becoming the diabetic capital of the world.
Right. Thank you, Dr. Geeta Lakshmi. And it's interesting you talked about the westernization as well. So, what is the prevalence of westernization really, and has it really contributed to the rising incidence of diabetes?
Yes, sir. Westernization has actually become increased to a very, very large extent, and it's not like based on the strata of the society. It's widespread. It's widespread across every segment of the society, and it's widespread in both rural and the urban areas. Westernization, to say in a manner, it has buried Indians to a great extent, and it has both positive and negative impact on the Indian society. The positive impacts being we get a lot of new technologies, new institutions, a lot of access to healthcare, not only healthcare, to almost in every sphere of society we have a lot of access. The technology has gone up in such a way, but in the same time, there's a great sophistication in food, dress, and manners, and because of this, there's a lot of dietary practices that has changed. I think we spend more of screen time. This is mainly attributed to the increasing prevalence of gadget usage in both children and adults. So that's one thing which leads to a lot of physical inactivity, which leads on to obesity right from childhood, leading on to increased prevalence of diabetes. And then coming on to the dietary practices, so we are more and more exposed to processed foods, and we are moving from appetite based, hunger based food intake, and we are moving to something called hedonic eating, hedonic hunger practices. That is, we can order whatever we want at whatever time we want. You can order something in Swiggy at 11 o'clock at night. Lot of Western diets, like processed foods which contain lot of trans fats, like pizza, burger, and fries. So many things are happening, and this thing has also contributed to increased prevalence of diabetes in rural areas as well, because previously rural areas, rice was a food of the higher society people, and the lower and middle class were primarily dependent on millets for their food resources. But now, because of the green revolution that has happened across the country and increased availability to food resources because of the westernization, almost every strata of the rural society has an access to rice, and especially people who are involved in farming, the farming laborers who do spend a lot of 12 to 14 hours in sunlight, they attribute to the hard work. They want a lot of access to rice. Almost their all their three meals is comprised of polished white rice, which has a very high glycemic index, again contributing to increased prevalence of diabetes across the rural population as well.
You talked a lot about the rural population. We saw a lot of, westernization happening in both rural and urban population. And the metropolitan city, the westernization is clearly much more. Like you talked about, having access to anytime food delivery services. This is much more severe in metropolitan and urban cities like Chennai, Chandigarh, for instance, right? Not so much in
Yes, sir.
rural areas, but still we find a lot of increased prevalence of diabetes. The rising incidence is there in both metropolitan as well as in rural areas, but in rural areas it is more so, even more so. So, any other reasons, any other things you can think about apart from the changes in dietary pattern, why it is so much increasing in rural areas, even faster than the urban population?
I think the major increase in rural areas is primarily because of the access. I don't think there's not much there. The technology is able to reach everywhere, it's able to spread its claws everywhere, and the rural environment is slowly becoming changing. More available city foods, the eating pattern is changing, and you get all these processed and trans fats and bakery foods, polished rice, and the sugar laden foods and drinks, what you get everywhere. I think that is the primary reason. And along with that, I think Asian Indian population is at an increased genetic predilection to diabetes as well. So I think diabetes is becoming more and more prevalent in the rural population. This is because of the reduced activity, and therefore we have a high risk of central obesity. I think that is one of the reasons why we are having more increased prevalence in rural areas as well.
Right, right. Plus, what I see over here in Chandigarh at least is that, those rural population farmers who used to work all day long in fields do a lot of physical labor. That physical labor component has gone down quite a lot. Either that has been outsourced either to another human, a laborer or something, or it has been outsourced to a machine, right? So over a period of time, the physical labor component of a rural population also has gone down drastically, and that's probably, then you have the deadly cocktail. The physical labor component has gone down, the activity has gone down, the children activity has gone down, plus the access to diet, as you beautifully pointed out, has gone up. So it basically creates a tough situation where the body's metabolism, on the top of a predisposed South Asian phenotype, leads to a very high prevalence of diabetes, higher visceral fat, and long term higher prevalence of diabetes occurring, and also higher chances of diabetes complications occurring. So that brings me to the next point. With all this thing, is there any difference in terms of approach of patients with diabetes, in terms of treatment options, or how should the Indian diabetic patients in terms of treatment options be differ compared to a Western or Caucasian counterpart?
Uh, Sir, as I've already pointed out, we Asian Indians are a very unique phenotype of diabetics. The onset of diabetes begins at a very, very young age for us, and there is we are all, as we funnily point out, we are thin fat population. That is, despite a lower body mass index, we have a great prevalence of abdominal obesity that's mainly marked by increased visceral fat deposition, and also the increased amount of insulin resistance we see, and the beta cell function, we lose it very, very at an early age. There's an early decline in beta cell function. I think, and one more factor which needs to be added here is we have a very high prevalence of cardiac disease at a very, very younger age. I think that's where our approach should focus. Because of these factors I have pointed out, the approach should be more personalized. We are supposed to move towards more of precision medicines. It should not be like one size fit all approach, and it should be a personalized approach relevant to these unmet needs. So this should be the primary principles to be followed in our therapeutic approach that should be there. And because of that, our focus should change. Primarily our focus, almost 20-30 years, based on the landmark Wikipedia study, was like, you bring down the HbA1c, you bring down the risk of complications as well. But right now, the focus has changed, the pathophysiology has changed. We know that it's no longer a disease of insulin deficiency and insulin resistance. There are multiple factors that are coming into play, like incretin axis, gut brain axis, so many things that are coming into play. So I think that's where our therapy should also undergo a change. Now we should focus on multiple aspects. we should take care of the glycemia point of view. At the same time, we should focus on the organ protection as well, because as I pointed out, there's an early risk of cardiac disease. So the protection against this cardiac and renal disease should start from the earliest. And also we should start hitting early and we should start hitting hard. So that's why we should start with a combination therapy at the start itself to focus on the diabetic therapy. So all these factors should change in the diabetic therapeutics to achieve a greater reduction in glycemia, as well as greater reduction in incidence of complications that are related to diabetes as well.
So why are Indian doctors choosing the therapy options which basically provide more of control beyond diabetes, like cardiac, renal, metabolic control? Also, why are these options still not among the higher up in the hierarchy compared to the conventional approach for management of diabetes?
In as Indian physicians, I think more of us have been sticking on to the conventional approaches, sir. I think that's the primary reason we are still very still skeptical about the newer approaches. We don't want to shift from the glycemic angle to the organ protective angle. But I think based on our previous discussion points, we know that we have a lot of diabetics more and more diagnosed at a younger population, and the pathophysiology is slightly unique in Indian population. I think all these factors put together, I think we need to modify our therapeutic approach as well. Instead of focusing from just from the glycemic angle, that is focusing on insulin secretagogues like sulfonylureas, I think we need to shift our focus to agents which can take care of the beta cell function and which can also offer organ protection, like SGLT2 inhibitors and DPP4 inhibitors, along with the sulfonylureas and the metformin. I think our approach should classify the patients. We should not try to fit all patients into a single under a single umbrella. Instead of that, we should classify our patients based on the age of onset, based on the glycemia, based on the risk factors. I think we should stratify the patients accordingly, and then we should modify our therapeutic approach accordingly.
Right. So very well said, Dr. Geeta Lakshmi. So, when we talk to our Western counterparts, when we meet them in meetings, we find that a lot of them, the patients who they are treating a lot of those patients and talking about time in range, talking about CGM, and it is much more commonly used in their practice compared to our practice. While if you look at with the food component that we talked about, the glycemic variability probably is equally prevalent, or if not more prevalent, in our population compared to the Western population. So, what do you think are the factors which prevent us from using time in range to such an extent that we can, that we should, and we are still sticking with conventional techniques for management, in terms of finding the where the glycemic patterns lie, and then titrating our treatment options accordingly?
Sir, I think we can answer this question from three viewpoints. The first viewpoint would be from the patient. Our Indian patients are actually more resistant to the newer technologies. Even in this current era of practices, convincing the patient to monitor their blood sugars on a regular basis with a glucometer is a big task. Convincing them to do it on a regular basis is a very very big task for us Indian physicians. I think our approach should target there. We should create more and more awareness among our Indian population. I think the education and creating awareness is the biggest yardstick to promote this aspect, so that we can motivate them to use the latest technologies. We can explain them the advantages. We can explain them what is a difference between the plain blood sugar monitoring, HbA1c, self monitoring of blood glucose, and the newer technologies like CGMs. I think the creating awareness and increasing the awareness to the patients. And the second aspect, breaking the therapeutic and clinical inertia from the physician's point of view as well. I think more and more slowly the increase in the CGM practices are increasing, but it is increasing only at the urban level among the physicians. But the primary point of care is the general practitioners, where our focus should lie. They are the ones who are treating diabetes at the first level. Patients often get referred to us at the last resort. We are the tertiary point of care. I think from the focus should start from there. So there also there should be lot of meetings creating awareness about these newer technologies, how they can be used for the benefit of the patients as well as the doctors. I think breaking that therapeutic and clinical inertia of the doctors would also help in going a long way. The third thing I would like to emphasize is the theme for the World Diabetes Day, that is the improving access to healthcare. So, access to healthcare to be improved both across the rural and urban areas, so that a patient who walks in from a village has an equal access to these technologies like glucometers and CGMs. So, the access should go up. I think that these viewpoints, I think we can go a long way in improving the diabetic care for our Indian population.
Right. Thank you so much, Dr. Geeta Lakshmi. It has been wonderful having you today for our 4D show, that is detailed discussion of Indian diabetics. I'm sure the viewers got a lot of carry home points, carry home messages in terms of how to improve the care of diabetic patients, how our patients are different compared to Western counterparts, how we should be not only counseling them more, but also try to be more proactive in terms of therapy options that we choose. So a lot of doctors will have a lot of valuable insights which will help improve the patient care for our patients. So before conclude, any concluding remarks, Dr. Geeta Lakshmi, from your side?
Yes, sir. I think we are seeing more and more diabetics these days, especially in the age of 20s to 30s. And our approach, this is a time that where the spotlight should be on changing our therapeutic approach, so that we can handle these patients better and prevent India from becoming not only the diabetic capital but also the capital for diabetic complications as well. So thank you, sir. Thank you. I'm honored to
Thank
be
you.
on the show. Thank you.
Thank you. Thank you. So very well summarized. So this is a time for us to be more proactive. This is a time for us to change our approach in terms of diagnosis, in terms of monitoring, in terms of management. This is a time to act in a manner, choose therapies in a manner so that we are not only the diabetes capital of the world, but we prevent ourselves from becoming the diabetes complications capital of the world. So thank you so much, and dear friends, we'll see you in the further episodes of 4D in the coming times. Till that time, have a very